Now I'd like to introduce Charlotte Massey.
Hello everyone, my name's Charlotte and I'm a physio working at the National Hospital for Neurology. Firstly, I just want to say thanks for the opportunity to speak about the work we've been doing in cough assessment and augmentation in MND, and it follows on really nicely from Diane's talk about breath stacking. So I just want to say I've got no disclosures, and I just want to thank the MNDA North London for funding my attendance here today. So I think we all know that cough is an issue in MND, and there's a lot of research coming out at the moment sort of talking about cough and cough augmentation in MND. Firstly, if we think about cough in general, we know that to get a good cough you need to take about 95% of your total lung capacity on inspiration. And then if you think about the bulbar function, you get closure of your epiglottis and your vocal cords shutting tightly together, trapping the air into your lungs. This then causes a big rise in your interthoracic pressure, and then you get the big expulsion of the air with your expiratory muscles. So we know that it involves both the respiratory system and also the bulbar system as well. So with our patients with MND, we get reduced lung volumes and weakness in their abdominal muscles. So this is the respiratory component, which results in an inadequate cough. We also need to take into account the bulbar impairment, which prevents this glottic closure and pharyngeal contraction, affecting mostly the expiratory part. So, as I said before, there's quite a lot of recent evidence and guidelines that have been coming out in the sort of management of cough in neuromuscular disease and MND as a whole. So firstly, if we think about the NICE guidelines, so the most recent NICE guidelines in 2016 covered a lot about cough, and all of this was new in the most recent guidelines. So firstly, it says we must offer cough augmentation, such as manually assisted cough, to people with MND who cannot cough effectively. There's talk about offering breath stacking as a first-line treatment, and then there's talk about patients with bulbar dysfunction and who have an ineffective cough, and considering adding in something supportive like a lung volume recruitment bag, which Diane just talked about. There's also some recent evidence from Tina Anderson, who did a study looking at putting in positive inspiratory pressures and how this can affect people who have bulbar impairment. So the kind of main findings from her study were that the application of any positive pressures for patients needs to be tailored to that individual. She found with nasoendoscopy that patients who have ALS and bulbar symptoms get laryngeal adduction, so their vocal cords tend to come together during insufflation, but also during exsufflation when using a cough assist. And this is something that we have to think about when we're thinking about providing cough augmentation for our patients. But I think there are quite a lot of unanswered questions, and I know our team at Queen Square struggle to know exactly about how we should provide cough augmentation. So firstly, when should we be giving it? I think we're not 100% clear on that. How do we decide which type of cough augmentation we're going to offer our patients? And what are the optimum settings and frequency for this? I think that was a question that was just asked before. How many times a day are we telling our patients to do this? How many breaths are we giving? And when are we telling them to increase the frequency? What is the best way for us to assess for cough augmentation? Which parameters are we using? And I think the big one that we've kind of found is, are there any risks with giving cough augmentation? Is there anything from giving cough augmentation that we're putting the patients at risk? So just a little bit of background about our MND service based at Queen Square. So we've got over 200 patients on our current caseload, so we've got quite a big caseload of patients. We cover patients from a very large geographical area, so our patients come in to see us, so we're based within the hospital and they come in to see us. As a physiotherapist, I see patients in different settings within the hospital. So in the MND clinics, we also run respiratory clinics. We have patients admitted onto our neurology wards, and we're also very lucky to have a neuromuscular complex care centre where we can bring patients in for MDT assessments, so sleep studies, respiratory assessment, assessment from the clinical nurse specialists, neurologists and therapists. So it's quite interesting that Diane was saying she was giving out breath stacking to patients who have a peak cough flow over 270, because we're actually doing the same thing as well. So we kind of split our patients almost into two. So the first lot of patients are patients that have a peak cough flow over 270 on their initial assessment. So at this point, we will issue patients with breath stacking exercises. ACBT is a term physios like to use, which is the active cycle of breathing technique, which includes deep inspirations, huffs and coughs. And we also give them information about the respiratory part of their disease and what they need to look for in the future if they have a decline. And then we will monitor our patients in our clinics, in respiratory clinic and on the neuromuscular centre, and we will do a peak cough flow every time they come in to see us so that we can monitor the changes. If a patient on initial assessment has a peak cough flow of less than 270, well, they'll be assessed by a physio and a speech therapist, either separately, and then we will discuss the findings, or we would see the patient together. And each patient is then given an individualised chest management plan according to their main symptoms and problems that they are having. And this is the sort of thing that we give them. I couldn't put both sides on, but on the back it's got like a traffic light system for patients to be able to see different symptoms and know kind of who to contact and how to change their chest management plan as their chest status changes. So we just collected a bit of data on our patients that we had seen between December 2017 and October 2018, and that includes 52 patients. The abstract, I think, has 16 on it, but that was just up until we submitted, which was in March, and so since then we've had a lot more. So the data that I'm going to talk about is these 52 patients who were under our service, and these are patients seen by physiotherapy or speech therapy. So all of the patients were assessed by physio or speech therapy, and then a discussion was had about them. And the following assessments were completed. So we completed a peak cough flow using the peak flow meter that was on the previous slide. When we do a peak cough flow, we always use a mask to make sure that the patient can open their mouth when they cough. All patients had a forced vital capacity. And this is presented in a percentage of what their predicted would be. All patients were asked on their mobility status, and for the purposes of the analysis of the data, we've just split that into independently mobile, mobile or transfers with an aid, or whether they required a full hoist to transfer. The type of MND diagnosis, and this was taken off the clinic letters from the neurology clinic when they were given the diagnosis by the neurologist. A number of chest infections in 6 months. The number of chest infections was a little tricky because patients either said no, they didn't have a chest infection, when we may then later find out that they did. So this was patient-reported chest infection, so it's not 100% sure how accurate that is. And then we also complete nasal endoscope assessments on patients if it was indicated. And I've highlighted indicated there in red because we're still working on our criteria to decide who we feel it is appropriate to do these assessments on and who we feel it's not indicated for. So of those 52 patients, here's just a little bit of a breakdown of the diagnosis, as I said, according to the neurology letters. So approximately half of the patients were ALS, and then we've taken out the ones that were given a diagnosis of bulbar onset, so if their first symptoms were bulbar, and there were 16 patients with bulbar onset. And then about a quarter was split between FTD, PLS, a respiratory onset, lower motor neuron variant, and then there were 4 who didn't have a specified diagnosis. So just important to say that this data is data from the patients when they were on their initial assessment by physiotherapy and speech therapy. So of the 52 patients that we assessed, 15 of them, so about 29%, had a peak cough flow of over 270. So they were given their breath stacking or ACBT advice and respiratory information. And then they will be reviewed on their next clinic appointment, which is approximately 3 months. And what we're going to talk about today is the data from these patients who had a peak cough flow of under 270. And we've taken this figure from all the work by Michelle Chatwin, who's based at the Brompton, who has found that with a peak cough flow of under 270, you are, if you get an infection on your chest, you are probably going to be unable to clear your secretions. So here's just a little bit of the data. I've just popped it in a table format. So of those 37 patients who had a peak cough flow of less than 270, there was quite a big range. So the maximum was 270 and the minimum we had was 50. There were 4 patients who couldn't complete a peak cough flow. So they were mostly patients with severe bulbar impairment. In regards to the FVC, again, we had a very big range between a minimum of 14% of predicted for that patient and 95% of predicted. And chest infections ranged between 0 and 3. We had one patient who'd had a number of chest infections. In regards to diagnosis, in these 37 who were less than 270, 20 of the patients, so about 54% were ALS, about 35% were bulbar. We had 2 with FTD and 1 each with a respiratory onset and PLS. And mobility status, we had 9 who were independently mobile, 13 who either walked or transferred with an aid, 15 who walked and transferred with an aid, and 13 who were fully hoist dependent when we saw them. So with these patients, we have split them up into successful setup with cough augmentation when we initially assessed them, and unsuccessful. So we had 19 out of 37 who were set up successfully after their initial assessment with cough augmentation. So 14 of those were set up using a cough assist device. And we're very lucky at Queen Square that we have readily available access to cough assist devices. I think in some other areas it's quite difficult to get funding for them. And then we had 5 who we successfully set up with a lung volume recruitment bag. We had 18 patients who, on that initial assessment, we were unable to successfully set them up with any form of cough augmentation. And the reasons for that I've listed here. So we had uncontrolled siluria, and that was the main reason. So 7 out of these patients had uncontrolled saliva that prevented us from setting them up with any kind of cough augmentation. We had 6 patients who had bulbar collapse, and this was bulbar collapse that was seen on a nasal endoscope when we completed that whilst trying to set up cough augmentation. We had 3 patients who, due to their cognitive impairment, they were unable to sync their breaths with any form of cough augmentation or unable to use the machine due to lack of carer support. We had 1 patient who was our respiratory onset patient who was just too breathless to be able to sync and use the machine. And we had 1 patient who had an unmanaged dysphagia, which meant that using cough augmentation was not safe for them at that particular time. So we wanted to ask ourselves if there was a way that we could predict when we assessed patients initially which ones would have successful cough augmentation setup and which ones wouldn't, using any of the predictors that we use within our clinic. So that would be FVC, mobility status, number of chest infections, type of MND, and peak cough flow. So I think we spent a lot of time thinking about, we wanted to find something that everybody is using day to day that maybe would be a good indicator. So these are our results. So if we look at peak cough flow, we found that actually the median between the successful and the unsuccessful group was actually quite similar. The range, again, was quite similar. However, the range for the patients that we successfully set up is skewed slightly higher. So none of the patients who were successful in being set up had a peak cough flow of less than 100 on initial assessment. And that sort of indicates to us that actually we need to be getting in there early with these patients and picking them up sooner, and sort of as soon as they start to get any drop in their cough, we need to be getting in there and trying to set them up with something, because once they drop down below 100, it's then very difficult to set them up. In regards to the FVC, we actually had a much wider skew of the data in the unsuccessful group compared to the successful group, and actually they had a slightly higher median of the FVC. We wondered whether some of that was to do with the cognitive factors, and also thinking about whether some of the bulbar factors were more involved with the peak cough flow as opposed to the FVC. In regards to the diagnosis, they were we had more ALS patients in the successful group compared to the unsuccessful, and more bulbar patients in the unsuccessful compared to the successful. And in regards to mobility, there didn't seem to be anything between the groups. And then if we look at the significance, there was actually none of these things were shown to be significant predictor of success versus unsuccessful setup. The one that we thought maybe getting closest was the peak cough flow, and that is the one we're actually using at the moment for our differentiation in clinic. So in conclusion, from initial assessment in clinic, we found there was only a 50% success rate for setting up what we call traditional cough augmentation, so a LVR bag or a cough assist with patients with MND. We found there was no significant predictor of successful setup versus unsuccessful setup in a general cough assessment. And I think the biggest thing we learned from this is there are so many different factors that you have to consider when thinking about a respiratory management plan for these patients. So recommendations. So at point of referral, physicians and therapists need to be aware of the possible barriers to cough augmentation, for example, cognition. And there's one example of a patient who, on initial assessment, we could not get her set up. She just could not tolerate the machine. We've since brought her back twice more and managed to set her up successfully with a cough assist with the support of her family. So I think it's about thinking about what can and can't be changed. Identifying and modifying risk factors. So another example of a patient is a patient who had unmanaged saliva when we first met them, and actually once that was managed with Botox and glycopyrronium, we were then able to successfully set them up with cough augmentation. And then again, thinking about dysphagia as well, and my colleague's going to talk about that in a little more detail next. We recommend that a joint assessment by a physio and a speech therapist is really important to try and manage the risk and benefit of cough augmentation and ensure we're providing a MDT chest management plan, taking into account all of the factors that are going on when we're trying to assess from a respiratory and cough augmentation perspective. I think as physios, sometimes we tend to just think about the lungs and trying to treat and manage that, when actually we need to take on board everything else that's going on. And any questions?
Thank you. That's really interesting work. Are there any questions?
I don't know how to. That's it. Okay. Can I just check? Are you introducing cough assist to them as a day patient?
As a, sorry?
A day patient.
Yeah, so yes. So they would normally have an initial assessment. We wouldn't set it up at that time. We'd then bring them back. And we've actually very recently set up a joint physio and SLT clinic for any neuromuscular patients, but the majority of our caseload is MND, to support with giving out cough augmentation and support with kind of managing all of the other things at the same time, so the excess saliva, the dysphagia, and giving a kind of MDT chest management plan.
And can I just check, are the community physios confident
So that's another thing that we've been doing quite a lot of work with is I've been going out to the AUG community team to go and teach them about the cough assist, and also we encourage the community physios to come in with the patient to their cough assist setup so that they can learn about the machine. The physios and other therapists in the community often don't change the settings, but they're happy with the machine and they know how it works. And we have quite good links with our local community teams. The big challenge for us at the moment is because we cover such a wide area is getting to the patients who are out of our kind of local boroughs.
Fantastic. That's a great piece of research. Thank you.
I have a question, if you can hear it. Are you able to compare the hospitalization rate to your cohort versus maybe another group?
I mean, that would be really good to do. We haven't been able to do it at the moment, but that would be something that would be worth doing in the future, I guess.
One more question. Down here. Oh. Quickly, one more question.
And I come from Drammen, Norway. I wonder if there's a situation when you might provoke kind of dry cough, because we've experienced one patient who we were unsure about whether she had we ought to kind of loosen up and get up some of the mucus, but we came to the conclusion it seemed to then and there to irritate.
Yeah.
Do you know anything about that?
That's something that we have looked at a little bit with some of the patients we've been unsuccessful at setting up. It is because actually the positive pressure invokes either stridor or a kind of dry cough, or they're unable to tolerate positive pressure. So one of the big things we notice is they just, and that's some of the work that Tina Anderson has done, where they just adduct at their vocal cords and close off their airway, which can then cause a bit of a cough response or a kind of blowing out of their cheeks. And with those patients, it's very difficult to change that. And for some patients, despite looking at the different settings and adding in things, turning down the pressures, we've not been able to set them up with any kind of cough augmentation, except maybe basic breathing exercises and other chest management things such as rescue antibiotics and things like that that they might have as an extra.
Even if they later seem to have more mucus? Or might you try again and maybe or is this a kind of...
So we would give the chest management to everybody, regardless of whether they have problems with chest secretions or not. We would give it as a kind of prophylactic, preventative treatment rather than a kind of acute management of mucus. If they get an infection and they get more mucus, we would advise that they use their cough augmentation more, but they are advised to use it on a day-to-day basis to kind of give cough support all of the time.
Okay, but this
Okay,
kind of...
I'm actually going to have to ask if you guys can continue that discussion later so we can move on. I apologize. But we need to move forward. So, thank you.
Thank you.